Hello, everyone. Thank you for coming. I'm Jonathan Lynch with CDC's Environmental Health Nexus. Welcome to day 2 of our workshop on applied epidemiology and environmental health. Next slide, please. Today's presentation will be available to view on demand approximately 2 weeks after this workshop on CDC's Environmental Health Nexus website. That's www.cdc.gov/NCEH/EHSP/EHNexus. The roundtable discussions will not be recorded. Next slide, please. We ask everyone to remain muted throughout the presentation. Please use the chat window to ask questions of the panelists. Next slide, please. The content and conclusions in this presentation are those of the authors and presenters and do not necessarily represent the views of, nor should any endorsements be inferred by, the Centers for Disease Control and Prevention. Next slide, please. Now I'm going to pass this over to Dr. Dana Flanders from Emory University. Dr. Flanders.
Thank you. So welcome again to the workshop on applied epi and environmental health. Let me start by thanking our two speakers today, Dr. Lance Waller and Dr. Scott Bartel, and also yesterday's speakers. I'm not sure whether they're listening in or not, but Dr. Jennifer Horney and Dr. Michael Goodman were our speakers yesterday. And their lectures yesterday, presentations, were recorded, and Dr. Horney's was on disaster epidemiology, and Dr. Goodman's was on investigation of cancer clusters. And those are both available also. So in case you missed it or want to review, those are there as well. Our goal in this workshop is to provide the opportunity to learn about, ask questions about advanced epidemiologic and statistical methods that can be used in environmental health. The emphasis is on applied and practical, but nevertheless state-of-the-art methods. Our speakers today are Dr. Scott Bartel and Dr. Lance Waller. And I'll say more about each speaker as we get to the just before their presentation. We identified, based on feedback from practicing environmental health experts and scientists, we decided on the topics, which will be briefly ecologic studies and use of group data in epidemiology by Dr. Bartel, and incorporating spatial correlation in public health analyses by Dr. Waller. We arrived at those topics and the ones also on day 1 through a feedback from practicing epidemiologists and public healthers, as I mentioned. And then we combed, we looked at the literature, we looked at publications, we looked at reputation to try to identify the top scientists in those areas. And we were lucky and happy that Dr. Bartel and Dr. Waller agreed to join us. So after each so we'll start with the presentations first by Dr. Bartel and then by Dr. Waller. After each one, using the remaining time for up to an hour, we'll have a question and answer period. But importantly, later in the day, between 2 and 3:45, we'll have a roundtable discussion. So you can ask additional questions, either ones that we didn't get to during the initial Q&A period, or additional ones that you think about during the roundtable discussions. And again, please use the chat function for that. Next slide, please. Oh, and then we'll have the closing remarks by Dr. Svensson. Next slide, please. So our first talk is using group level variables in epidemiology by Dr. Bartell. Dr. Bartel is a professor of environmental and occupational health and statistics at University of California, Irvine. His research interest is environmental health methodology, or includes, I should say, environmental health methodology and applications in environmental exposure science, pharmacokinetic modeling, and risk assessment. Dr. Bartel earned his bachelor's degree in environmental science from University of California, Berkeley, and his MS in environmental health from University of Washington, and his MS in statistics and a PhD in epidemiology from University of California, Davis. I know I've sold him a bit short, but in the interest of time, I've made it my little description a bit brief. But Dr. Bartel, please.
Thank you, Dana. Don't worry, you haven't sold me short. If anything, you've had too many kind words here today. So I'm going to go ahead and share my screen. Give me a moment. And hopefully everybody can see my slides for today using group level variables in epidemiology. So I'm going to start with something a little bit simple, and I understand there's a wide variety of backgrounds here, from maybe some folks who have never taken an epidemiology course to some who might have a PhD in epidemiology already. But we'll quickly get more complicated. So I promise, and I'm going to try to keep this high level so we don't get too much into the weeds on the math. But I think even if you have a PhD in epi, you'll find there's a good chance we'll get beyond the ecological studies into some study designs you maybe haven't even seen before, because they're definitely not part of standard epi training or textbooks. But we're going to start simply with a figure actually from a common intermediate level epidemiology textbook by Sklo and Nieto. If you've taken a little epi, you've probably seen something like this before, but it's just a plot of 10-year coronary death rates per 10,000 men on the y-axis, compared to a country level. So there's a group level measurement of percent of dietary calories from saturated fat on the x-axis. Right, and in this particular figure, they've done a regression to get the overall trend, which you can see is increasing.
I'm
Oh,
sorry.
yes.
I don't think you're there. It didn't advance, at least on my screen, but now it did.
Thank you for letting me know that. I, for some reason, have some difficulty when I'm in presenter mode with my Zoom. So I'm going to actually back out, and unfortunately, this will make the slides slightly smaller, but hopefully everybody will still be able to see. And I think outside of presenter mode seems to make it easier for Zoom to catch up for some reason. So apologies for that. Let me know, please, if it happens again, and we'll try a third method. But so at any rate, what I was talking about this figure is just, a kind of classic example of an ecological analysis or an ecological study design in epidemiology, where we're taking group level data, such as coronary death rates and percent of calories coming from saturated fat, all measured at the level of country, right? And this could be any kind of group aggregation, and it would be ecological. But this is a sort of classic example where if we line up countries by their coronary death rates and by saturated fat in the diet, you see a pretty clear trend of increasing death rates as saturated fat percentage goes up country by country. And by the way, this doesn't have to be a regression model that you're fitting for it to be ecological data. You could do a variety of analyses. You could group these countries into high, medium, and low groups by saturated fat, or even just a high versus low comparison. You could make this categorical, and it would still be ecological, right? So being ecological doesn't come from the statistical method like regression that you're using to analyze the data, but rather from the fact that your measurements of your variables are all at the group level rather than measuring diets and coronary death outcomes in individuals. Okay, so again, the key concept with ecological studies is that our unit of observation, where we're doing our measurement, is in groups, not getting measurements specific to individuals. right? So a few other examples to help illustrate this could be, for example, comparing heart disease rates in Japan versus the US, where we're grouping by country as we did in the last slide. We could also compare at other levels of geographic aggregation, like by county. So cancer rates by county versus average age and average income, where we're looking at those characteristics, the age, and average income by county, right? So all our variables are measured by county. And we might get that data, for example, from US Census for things like age and income, maybe cancer rates from a cancer registry. Another example, autism rates in schools near coal-burning power plants versus schools farther away from plants. This actually comes from a study I published some time ago. And the group here is actually the school. So these don't have to be necessarily geographic units, right? Anytime we're just aggregating people into groups, we're talking about and then only obtaining the measurements at the group level, we're talking about ecological designs. So these designs are easy, relatively speaking, easy to implement, and increasingly now we have public use data available that would let us do these kind of studies. We've got publicly available disease surveillance data, often by state, sometimes even by county. We've got US Census data for demographics in particular. And so generally speaking, when we use these kind of sources or any other kind of source where we've got measures in groups rather than individual, statisticians often refer to this as aggregated data. It's the same idea as group level or ecological data. Now, the problem that comes up, which epidemiologic textbooks warn about quite a bit, is that aggregating by group can lead to incorrect inferences about the effects of exposures on individuals. So when we're lining up disease rates by group and then comparing them to group level exposure measures to see if there's a relationship, the challenge is that that relationship we see at the group level may not actually hold at the individual level. And so doing this kind of analysis and making that interpretation as if it's a individual level association is what epidemiologists will refer to as ecologic fallacy. Now, in fact, sometimes the group inferences do extend to individuals, but not always. And we'll talk about that a little more shortly. Here's a great example of ecological fallacy that is a classic example. You've probably seen it before at some point. If you've taken an epidemiology course, there's a good chance you've run across this. Dates back to 1950 paper. So this has been around for a long time. It's a popular example, but it's pretty clear and I think pretty intuitive to get a handle on. So I'm going to repeat it here. And again, it might be new for some of these who maybe not taken an epi course who are here today. So English literacy was higher in states. This is obviously an older data set going back some time. Literacy was higher in states with higher percentages of foreign-born residents, right? Which might seem counterintuitive that that states of high proportions of immigrants actually have higher English literacy rates. Right? And you see a moderate correlation, R of about 0.46, and at that group level, right, comparing literacy rates state by state with the percentage of foreign-born. Now, in fact, though, if you obtain individual level data, which was done in this study, then you see at the individual level, when you correlate these two variables, that the correlation is actually negative instead of positive. Slightly negative, about negative 0.12 among individuals. Right? And so the interpretation, right, of these two correlation coefficients, the first at the group level, the second at the individual level, is that foreign-born residents were less likely to be literate in English individually, but they are more likely to live in high literacy states, which makes some sense if you think about it, because immigrants are often attracted to states with vibrant economies, which often tend to also be located in high literacy states. Right, so the difference in these results is due to, again, what we might call ecological bias, or often in the statistical literature called aggregation bias. Same concept. The fallacy is not in reporting a group level association. There's nothing wrong about that first correlation coefficient at the group level of 0.46. It's a perfectly valid correlation at the group level. But the fallacy is actually in attributing it unambiguously to the individual level, right? So if we take that 0.46 and interpret it incorrectly to say that that foreign-born residents are more likely individually to be literate, right? That's where the fallacy comes in. Now, there's some other things that we should talk about with ecological designs. One of the main things to know is that beyond the challenges of just interpretation, right? Because I think we all look at correlation coefficients at the group level or regression coefficients, odds ratios, other measures of association, and we really sort of want to interpret those as if they were individual level associations. However, even if you strictly interpret at the group level, there is some challenges to actually correctly adjusting for confounding. And generally, it's going to be problematic unless the confounders are, in fact, simultaneously stratified by both exposure and disease status. Sandra Greenland wrote a nice paper about this about 2 decades ago, and I'll show you one of the tables from that paper a little bit later to sort of better explain this. So for example, you know, if we're doing a case control analysis or even just comparing disease rates across counties, and we thought, well, you know, we know smoking rates might differ across counties. A sort of common approach in ecological design would be to obtain an estimate of the smoking rate, perhaps from BRFSS or another source, at the county level, or sorry, I guess I've got country here, right? So at the country level. And then sort of enter that into our model, whether it's a regression model or in a stratified analysis, attempt to use the smoking rates as a whole for each country to adjust for those disease rates. Now, the problem is that doesn't necessarily do the correct adjustment that we want if those smoking rates are not also stratified by disease status. In other words, ideally, we'd want separate rates of smoking for the disease cases versus the disease controls in order to do a proper adjustment for confounding, even at the group level. That all being said, we can, you know, pretty clearly now, looking at a wealth of data from epidemiology at the individual level, conclude that saturated fat consumption does appear to be associated with coronary heart disease and deaths in individuals as well as in groups. Right, so even though we did have on our previous slide this this figure, you know, kind of doing the ecological analysis, we know there's, you know, challenges, there might be problems with interpretation, with confounding adjustment. Nonetheless, we actually do see a similar association between saturated fat and coronary death at the individual level. And so it's important to understand, right, that just because there's a possibility of aggregation bias or ecologic bias, that doesn't necessarily mean that it is there or that it's substantial, right? And so I believe, and I think a lot of folks believe, there is some value to doing ecological analyses. Frankly, a lot of epidemiologic textbooks are fairly dismissive, and there are, you know, a lot of limitations to these studies. But sometimes they actually give you the right answer, despite the possibility of bias. Okay, so here's actually the first table from the Greenland paper, which I mentioned earlier, that kind of illustrates a little more clearly why control for confounding is challenging in ecological studies. And before you focus on the numbers in the table, you can read the notation at the bottom, and I'll walk you through it, kind of explain this. But basically, this is kind of a hypothetical example where we've got 2 groups we're comparing. So you can think of these as 2 neighborhoods or 2 counties. So group A and B are the 2 groups, and so that's our exposure status, right? So in this case, where maybe our exposure is which county you live in, and we're very interested in the contextual effect of that county with regard to the impact on the disease rate. Then X is the confounder status, and it's measured at the group level in group A and B. And again, this could be something like smoking, right? Whether the sort of rate of smoking in the 2 groups, right? It's just, again, something we might be able to get a handle on from sort of aggregated data sources. Y is the disease status, again measured at the group level in groups A and B. Right, and you can see we basically have the same rate of disease here. These are in thousands of person years, the denominator. So we have disease rates of 5.6 cases per 1,000 person years of observation in both groups A and B. All right, so based on an ecological analysis, we might say, okay, well, it appears that there's really the comparable rate of disease across these two groups. We're good. We can go home. Even though there's different levels of the confounder, we can see 3/5 of group A has the confounder x equals 1, whereas only 2/5 of group B has the confounder. Right, so we've adjusted for confounding at the group level, and we see, okay, we have comparable rates. Now the challenge comes in, though, in that we really we don't actually know the entries we would need to fill in the fully stratified table to compare these disease rates, adjusting for smoking multiply stratified by disease status, which is the Y row here, right? So we may know the overall rate of disease, we know the overall rate of the smoking in each group A and group B. That still doesn't give us enough information to fill in the entries for the confounder status for group A or group B in among the cases, right, among the Y equals 1 row. And Greenland shows in a couple other tables in the paper that I won't go through today in the interest of time, that actually you can fill in these entries in a variety of ways that are very consistent with these tables, that actually give you much different comparisons. You could have group A actually have twice the adjusted group disease rate as group B, or vice versa, group B having twice the adjusted risk as group A, or any other number of relative risks comparing group A and group B. That could go in either direction depending how you fill in these entries. So this is one of the main take-home messages from today, is that even though we can do these ecological studies, we can interpret at the group level, we have to realize that we're not going to get complete confounding control if we don't have the confounder fully stratified by both the case status and our exposure status, which is necessary in order to really do a fully adjusted comparison. And essentially, when we fit the model only using the group level confounding variable, what we're doing is that we're assuming that the breakdown of the 560 cases in each group essentially falls along the same lines as the proportion in each of these two columns, right? That we have roughly 3/5 of those here and 2/5 of those there. It's kind of not obvious, but it's an implicit assumption if you just go ahead and adjust for non-stratified smoking status, right? Where you just have that at the county level, but not also by case status. And if you think about it, that's actually a horrible assumption, because what that is assuming is that that there is no relationship between the confounder and the rate of the disease outcome. And in fact, there should be, right? If it's a confounder, we expect it to be associated with both exposure and disease. And yet we're kind of making an alternate, a contradictory assumption in order to analyze the data without the fully stratified numbers here. Okay, so in practice, we have to, recognize that substantial aggregated data are now publicly available, right? So they're easy, fast, inexpensive to analyze, and we're all going to do it anyway because the data are there, and we're going to use what we can to try to get a handle on these associations. But we have to recognize that there is a good reason that ecological designs are historically pretty much disparaged by epidemiologists. Often we refer to them as hypothesis generating, and generally speaking, it's a really good idea to confirm these by individual level epidemiology. Now, that being said, there's increasing recognition and interest in potential group level disease determinants. The epi literature in the last decade or so is full of examples, particularly as we think more about social epidemiology, of contextual effects from things like neighborhood. Issues like social capital, we talk about food deserts a lot, medically underserved areas. These are all factors that aren't necessarily operating at the individual level as much as the group level. And they're things that might actually be more appropriately leveled, measured at the group level as characteristics of neighborhoods or counties. So what we've seen now in recent years is really more considering and incorporating both individual and group level variables in epidemiologic models, especially when large group level effects are expected. This is just a nice example actually from one of CDC's websites for violence prevention. They talk about the social ecological model, which you may have heard of. This is becoming increasingly popular as a way to sort of think about the fact that we do have these multiple levels of effects on health, from individual factors, which have been the along the traditional focus of epidemiology, to broader contextual factors from, relationships, for example, being in a relationship with a gun owner, to community level factors, to societal level factors, right, that all have interplay in terms of risk of disease or other health outcomes. Okay, so quickly, I'm going to kind of take you through some study designs that can be used for incorporating individual group and individual level data without aggregation bias. There's quite a lot of it here, so we don't have time to get into many details, but we can talk about these further in some of the questions. I'm going to give you a very high-level overview here. There's going to be a little math just to help illustrate why some of these methods work, but we won't get into likelihood functions today. But just for a rough idea of what we're talking about here, just consider here for now as an illustrative example. It's not the only type of model that can be fit to these data, but a common type of model that we use in epidemiology would be a model for binomial outcomes, or really Bernoulli outcomes, where each person has a disease, which is denoted by YKI equals 1 for group K, individual I, or does not have the disease, in which YKI is equal to 0. And so we have a probability model for that that depends on covariates xki and unknown parameters beta, is shown as a vector here of unknown parameters. We have a link function g. Typically, for example, we use in epidemiology quite often the logit link for logistic regression. That could be any link. And again, these methods don't necessarily require even Bernoulli outcomes, yes/no outcomes. We can actually use a lot of the methods we're talking about even with continuous outcome measures. So it doesn't have to be a yes/no measure. But since that's sort of the predominant model used in epidemiology, and in our paper, we talk primarily about these Bernoulli models. We're going to kind of focus on that today. And then I'm just going to add that, often we can add some richness to these models by adding additional smooth effects or random effects of additional covariates, which I'll refer to as ZKI. Again, measured at the individual level, but recognizing that the individuals are nested in groups, which are denoted by K. Right, and that, for example, with smooths would be noted by a plus a smooth S term, which is potentially dependent on those covariates, ZKI. Okay, so probably the most widely used method for integrating group and individual level data is just multi-level analyses, right? And so these analyses generally assume that we have exposure, outcomes, and confounders measured at the individual level. However, we're going to recognize that the individuals are in fact nested in groups like neighborhood, county, states that may also affect their health outcomes. Right, so we can measure the group level characteristics and enter them specifically as covariates, usually in that ZKI with either smooth effects or random effects for those characteristics. But we can also model them without having to measure the specific contextual factors that occur in neighborhoods or counties that might be affecting disease. These unmeasured group characteristics are often handled via random effects or by correlation structures in generalized estimating equations. For example, if we have, for example, the logit probability of the outcome is xki beta plus alpha k, where alpha k has a normal distribution that varies from, say, neighborhood to neighborhood, right? And so, again, we've got k as the group, so each value k could represent a different neighborhood. That would be the simplest sort of random effects model structure, where we allow the logit of the probability of disease to vary from county to county, in addition to according by individual factors to what risk factors individuals have. All right, so these methods, actually there's a very nice review paper by Diaz-Roux in 2000. All my references, by the way, are at the end of the slides. So if you're looking for any of these, we'll be sharing the slides, and I'll show them briefly on the Zoom call today. So you can go find these. And I tried to pull out kind of approachable summary papers for the most part that kind of are good starting points for getting a handle on these methods. A good example of multi-level analysis is a paper by Congdon, 2009, on cardiovascular disease prevalence in the US, which has over 330,000 survey responses in 2005 from BRFSS, individual level covariates on age, gender, ethnicity, and education level. Measured group level covariates include county poverty rates and county urbanity rates. So those are, again, specific characteristics of counties that are being put in through the ZI covariates or the X covariates. And then we have group level random effects. Again, these are now unmeasured characteristics of states that they also decide to model as well. So we have a state level effect with spatial correlation, assumed to be, some correlation of states that are physically close to each other. We've got state level effects specific to ethnic group in the final model. And the authors concluded that there are significant spatial effects, that is county poverty effects and state residual effects from unmeasured characteristics, after adjusting for cardiovascular disease gradients over person level variables, namely age, education, ethnicity. And this is really, I think, in my mind, probably the ideal type of analysis you want to do if you're concerned about modeling sort of both these contextual group level effects, both measured and both through measured and unmeasured characteristics, as well as being able to actually get the individual level data to address the effects of individual level risk factors on disease. Another example that I would put in the category of multi-level is survival analysis of advanced state ovarian cancer patients in California. Here we have individual level data on age, race, and insurance status. And actually, technically, our group level variable here is actually individual residential geolocation. So we actually have this for each cancer patient, a geocoded residential address at the time of diagnosis. And then we are using a model that does a bivariate smooth of the effect of that geolocation. Now, but I kind of look at that smooth, even if the geocodes are individual level, what we're doing when we smooth the effect of geolocation is actually we're taking information from people who live near that case, other cases who live near that case, and in some sense aggregating them. It's sort of a complex weighted average, but it's still an aggregation geographically. So even though we've got some individual level data, I actually consider this a way of trying to get a handle on what's the group level effect of where you live on survivorship from ovarian cancer. This, by the way, is a map you can generate using the MapGAM package. It's a package I maintain on CRAN in R. There are certainly lots of other methods for spatial analyses, and I know that Dr. Waller will be speaking about that quite a bit for his session. So that's all I'm going to say about spatial, explicitly modeling the spatial effects today. I do want to talk about some other designs that you probably will not see in any epidemiologic textbooks that I'm aware of. I certainly wasn't trained in these. A lot of them have emerged since I was trained, which was many moons ago. One of these designs, and these, by the way, are covered, this design, in our review paper by Hamnoose and Bartel in 2011. The bottom, if you want more details, the Martinez paper 2007 is got the mathy stuff in more detail. But the aggregated data design is really just an idea for and a methodology for handling the situation when the outcomes are only available at the group level. And sometimes you just can't get individual level data on some of your outcomes, or at least it's impractical to do so. And again, we have all these sort of group level public use sources available. So this is a clever idea for how to use those. So it turns out that unbiased parameter estimates can be obtained even from the group level outcome data if you have access to individual level covariates, even though those covariates may not be linked to individual level outcomes. And why this works is kind of interesting and a little surprising, but the idea is that a representative sample of each of the groups, however you're grouping people into these groups K, by county, by neighborhood, a representative sample of each group is actually sufficient if you can obtain some individual level covariates for the risk factors that are of interest. Right, and the way this works is basically to recognize that our same probability model from a few slides back can be now aggregated. Remember, we had a probability model for pi ki that was related to the covariates xki times beta. If we basically take the inverse link function, that's equal to the probability. And then what we do actually is we can actually average the probability model across all the individuals, all the i's in group K, and write down the expected proportion of cases in group K as pi k. And we actually have an explicit now model relating the individual level disease factors, risk factors, xki, to the group level risk of disease, pi k. Right? And so it turns out when you write the model this way, it kind of illustrates why that we don't actually need the individual YKI, because the sufficient statistics for beta really just require knowing the total observed proportion of cases in group K, not actually the individual YKI values. And so this leads to a variety of statistical approaches that, again, we kind of briefly review in the paper, but include things like semi-parametric estimate equations and hierarchical related regression that can be actually used to, again, combine these two sources of data, group level outcome data, and then individual level survey data, which doesn't even have to be complete for each group, right? So again, if we can get a representative sample from each group K, then we can use that to actually get unbiased estimates in the aggregated data design. So we're going to see this this data set. This is actually an example used throughout the review paper on low birth weight in North Carolina with just over 200,000 births in 100 counties in North Carolina during a 2-year period, 2003 to 2007. Here's kind of what the data look like, graphed, plotted out by county, percent low birth weight with a sort of shade gradient. A darker shade is a higher percent of low birth weight. All right, so we see quite a bit of variation county to county. We've got group level measures of percent of low birth weight by county as the outcome variable. We've got individual level data on infant race and sex. You know, just as a note, the aggregated data design is more useful for covariates not on the birth certificate. This is kind of an example we're using more for simulation, to motivate a simulation study to compare these methods. But in practice, right, you know, generally speaking, you're going to probably be using this design on things that, you know, you're going to actually be surveying people to obtain. Individual level covariates can be obtained from de novo surveys or from existing data sources. In some cases, you know, BRFSS, you know, depending on the sort of level of aggregation you want to get to, you can, you know, sometimes obtain these things at the individual level. Sometimes that requires, you know, special permissions for data access. For example, for federal data like US Census, you would have to go into a research data center and propose this to NCHS, which has to approve the study before you go. But those kind of individual level data are sometimes already available if you go through the proper access procedures. If individual level outcomes are also available, then it turns out this integrated ADD design, the aggregated data design, performs better than group level only data, right? So again, if you have the ability to even do a small representative survey of those different units, these different groups that you want to study, then you can actually get again some substantially better estimates than you would from just a sort of classic ecological analysis. Another method I want to introduce you to, which is, an old idea, but it turns out not much discussed in the literature. And so we weren't able to sort of find anybody kind of clearly addressing this or even deriving some of the equations we used. But the idea here is that actually, as I mentioned earlier with Greenland paper, if you actually do have the ability to stratify multiply by all covariates, the group level outcomes, right? In other words, going back to that Greenland example, right? If you get the disease rates and the confounder rates broken down by the exposure status and by group, and all other confounders, right? So simultaneously stratifying by all the covariates that you want in the model, then you can actually recover individual level effects. And again, hearkening back to our probability model, if we have pi k is that group level risk of disease or group level expected proportion of people with disease, then it turns out that everybody in the group will have the same risk with regard to the covariates if you actually get the fully stratified, multiply stratified simultaneously by all covariates. Then within the stratum K now, and the one shift here we have to make is thinking about the stratum not as the groups themselves, but the fully stratified observations, right? So for every combination of smoking, exposure, location, we have all the other covariates measured, right? Then we actually have identical XKI for every person within the stratum, right? Because we've fully stratified by all the covariates that we want in the model. And that means that everybody in the group in the stratum K has the same values for XKI, which means that we don't actually have a need to average it because everybody has the same value for pi ki. And so we can just call that pi k. It's identical for everybody in that group K. And then the model for the outcome, the probability model, is just that it's got to be then binomial because we've got independent observations. Everybody has the same probability. Right, and so it turns out that once we've fully stratified multiply by all the predictors, we can get just our correct estimators and standard errors just by standard logistic regression. It turns out the likelihood is exactly the same for this binomial model as for entering the data one person at a time, always with the same covariates with the same group K, and then just taking the product likelihood over those individuals is literally just the binomial probability model. So we're essentially actually fitting the right model when we do that to get individual level betas. Now, things get a little more complicated if you have a continuous outcome. So for linear regression, we do need not just the mean of the outcome level for each stratum, but also the standard deviation. And then we use inverse variance weighting, and we've derived some special formulas to account for this structure for getting the correct standard errors. So you will need to do a little more legwork if you want to apply this method to continuous outcomes, but the formulas that you need for that are in our 2020 paper by Sue and Bartel here. Okay, so brief example of this. We have PFAS water concentrations, continuous birth weight, again with means and standard deviations available for every county, and hypertensive disorders of pregnancy as our outcome among more than 8 million singleton births in the US during 2013 to 2015. This is all done with public use data in our papers. So from CDC Wonder, we're able to get birth weight data and the HDP data, and do this at the county level. If you go through the CDC Wonder request, you can actually ask for these outcomes multiply stratified by a number of characteristics. So we did that for maternal age, race, education, smoking status, and parity. And then we got county level PFAS water detections and concentrations from UCMR3. These are not, unfortunately, stratified by outcomes or other covariates, but they are available at that group level. And so, we can show basically mathematically that the effect estimates, the betas and the odds ratios that we're getting from these studies, or the average change in birth weight per unit increase in PFAS, are equivalent to those that we would have obtained using county level exposure measure, which is this water concentration average for the county, and individual level individual level data on the birth weight and all of those confounders, right? And so we're very, very close to what we want, as maybe more of an individual level effect estimate, but we still had to rely on group level exposure. So there's still, some potential for a little bit of aggregation bias there. If you want to get to the effect of individual level PFAS exposures specifically. That being said, with these analyses, we observed similar associations with PFAS to those reported in smaller individual level studies that mostly had used measured PFAS serum concentrations from individuals. We also did have to exclude some counties due to missing UCMR3 data or CDC suppression of the public use data for small counts. This wasn't really much of an issue in terms of the CDC suppression for the birth weights, but was a larger issue a little bit for the hypertensive disorders. We had to, basically got only about 71% of the pregnancies actually had usable data after the CDC suppression and missing UCMR3 data. Okay, I know we're kind of getting close to time, so I'm gonna kind of maybe do a little less detail on the remaining designs. But I do want to talk about some of the other ideas that are out there in terms of models. Two-phase designs are another idea. If you have some variables that are known and enumerated for everyone in a population with group level summaries available, for example, by county from the US Census or from birth certificates, death certificates, you consider those data what we're going to call phase one, right? So these are sort of available at the start before you even launch, the second part of the study, phase two. The idea for the two-phase design is in phase two, you're going to use the data from phase one and the characteristics that are measured in phase one to actually efficiently sample individuals from those groups, for example, by county, or by strata identified by group level characteristics. So for example, if you in fact know things like the racial breakdown by county, which is often available from US Census, then you can actually stratify and sample at phase two according to grouping counties by those who have a high versus low non-white prevalence. Now the key insight in the two-phase design, I mean, you could always do this sort of two phases without doing anything differently on your statistics, but then you're sort of wasting the phase one data. Turns out you can get a little more efficient estimates of your effect sizes of the betas by actually incorporating the data both from the group level of phase one and the individual level data that you collect during that sampling individuals in phase two. Okay, so again, returning to the North Carolina birth weight example, part of our simulation study included comparisons of different two-phase sampling approaches, sampling by county alone, or then stratifying the counties into groups, into 5 groups of counties by percent non-white births, using the phase one data we already have from the census available on that, or by in this case from the birth certificates, or by stratifying by county-specific percentage of male births in 5 categories. Because the strata are used for oversampling rather than matching, the effects of the stratification variables are still estimable. So we can still estimate the effects of individual level non-white birth and male birth on the low birth weight risk. And it turns out the race-based phase two sampling performed best in our simulations. And this isn't too surprising because this method will perform well when you have strong variations across counties in that risk factor that you're using to design your sample, and especially if it's also a strong predictor of low birth weight or your outcome. Finally, I want to introduce hybrid designs. This assumes that group level outcome and covariate are available. Individuals can be stratified by outcome status for sampling, and that the individual level covariate data stratified by outcome are collected from each group. The analysis does not require but benefits from individual level representation from every group or stratum, right? But it doesn't actually require that you collect data from every stratum, which is interesting because it allows things like a registry-based case-only sample. So you might consider this kind of design if you want to do a study on cancer but you only have, detailed information on cases in a cancer registry, right? But you can then combine that with group level, say, census data or group level data on other covariates to employ this kind of design. Estimation proceeds via the induced hybrid likelihood, which is just derived by averaging the individual level likelihood over all the possible configurations of the unobserved complete individual level data. This is the most complex statistically of the approaches. It's very computationally expensive. I've only actually seen this done for categorical covariates. I'm not sure it even exists yet in terms of anybody having developed the equations or implemented the method for continuous covariates. And so this is definitely a little more challenging. But for example, we have in our simulation low birth weights and demographics available by county. And then consider supplementing that with an individual level survey on low birth weight and demographics. So again, we're collecting here low birth weights both at the individual and the group level, right? And taking advantage of the fact that we can sort of do this at multiple levels and then write down the likelihood that combines all the data. And the individual level survey includes, in the first approach, 250 cases, 250 controls from each of the 4 largest counties, and then a case-only design for the second one with 250 cases only. And the hybrid design was actually more efficient than the comparable aggregated data design or two-phase designs, and similar efficiency actually for the 2 designs discussed here, the case control and the high case-only hybrid designs. But the efficiency gains may be due as much to the statistical method. This induced hybrid likelihood is really ideal in that it's fully considering both levels of data, but also how they interact. The fact that the group level data is actually made up of individual level data. And so it's fully accounting for any restrictions and the nature of the relationship as part of the model between those 2 levels of measurement when we're measuring them at multiple levels. All right, and in the interest of time, to leave some time for questions, I'm going to skip over the details, but basically these methods are all unbiased as we'd expect, and the paper goes into comparisons of the relative efficiency. We can talk about that later if people have questions. Take-home messages: don't be afraid to use group level variables. There's a lot of approaches available. They all have some limitations, and depending on which design, the different limitations. If you're using completely ecological studies where all covariates are at the group level and they're not available, fully multiply stratified, then you've got some major limitations, as we discussed at the start. But various study designs and statistical methods are available for combining group level and individual level data without aggregation bias, or to minimize the aggregation bias as much as possible. The multi-level models are widely used and implemented already in existing software packages, GEs, mixed effects models, other approaches for spatial data are widely available now, and they just require individual level data on outcomes. If you can't get individual level data on outcomes, then really consider those other methods and whether they might be suitable. But just recognize you're not going to find those largely in epidemiologic textbooks, and most of us weren't trained in those methods. A lot of them are relatively recent, but the necessary formulas are published so they can be implemented. I'll finally end on just disclosures. This is every research funding source that I've had in my career, and just in the interest of full transparency, there it is. And also, my university would like me to mention that I do serve as a compensated expert witness for PFAS medical monitoring lawsuits in New Hampshire, and they're aware of reviewed this arrangement. And since I have PFAS on a slide somewhere, I'm supposed to put that on there as well. References, here are the first set of references. These are alphabetical, not quite complete, and then more references. And that is my talk.
Well, Scott, thank you very much for a great, stimulating and informative presentation. Really nice.
My pleasure. Thank you, Dana.
As you were speaking, a number of questions came in the and maybe we won't get to all of them, and we have about 6 minutes until we're going to take a break before Dr. Waller's talk. But there is, let me remind everybody, there is a roundtable, and Dr. Bartel will be available to address additional questions at that time. So if your question doesn't get addressed now, please raise it again, and we'll, I think, keep track of them also so we can ask them at that time. So let me start off with asking you something. I'm not sure it was raised over here, but in the chat flow, but you presented 5 different methods, I think it was, and they all have some strengths and probably weaknesses. I know one was very computer intensive, but they all seem to be unbiased. But how would you choose between these methods? What can you give us some general, hints about that?
Yeah, sure. So I mean, it is, it really depends on the context of what data you can actually get. I mean, and for me, that's how I kind of think about these methods is what can I actually obtain? And how detailed can I get in a practical way? Obviously, with enough time, effort, resources, you can do quite a bit at the individual level. But in fact, we're often limited in time, we're limited in resources, and we want to get it. Even if it's not the best possible answer, we want to get as best an answer as we can get with the available data, in a reasonable time frame. So I think I first start by thinking about can I get the individual level data? That's always ideal, right? To start there. And if you're interested in studying contextual factors and group level effects, make sure you choose statistical models that actually recognize the fact that these individuals are nested in groups. So the multi-level models are a great approach for this because it actually, assuming you can get the individual level data on most of the factors, it allows you to, make sure you're getting unbiased estimates, incorporating really the best information at the individual level for individual level risk factors and outcomes, but also allows you to incorporate both measured and unmeasured group characteristics. And so, that's sort of the go-to method, I think, for most situations and most people, if you're able to get that level of data. If you can't get the individual level data and that you're sort of stuck at the group level, then at least try to get stratified group level data as much as possible, stratifying by not just by exposure, but also by disease status and by any other confounders that you can get stratified. Because the more you stratify, the better confounding control you're going to get. Right. And so that's, I think, another important take-home lesson. If you're sort of at the other end where you can't get individual level data at all, you're stuck with group level data, try to get it at least broken down and stratified as much as possible across all the other covariates. If you're somewhere in between, things get a little more complicated, right? Where you maybe have some group, you've got group level variables, you've got some individual level ability to get individual level data, and then it really becomes more of a question of what you have time and ability to do, and I think there the context becomes a lot more important. It depends on how variable those factors are across the different groups that you're comparing. Depends on whether you can get those data sort of in a very resolved way at the individual level, whether you can get outcomes at the individual level as well as the group level, in which case that hybrid design really is kind of ideal. But it's probably more of a discussion you want to have with a study design expert or a statistician who's familiar with these areas of work, when you sort of have a specific context that you really are trying to address.
Well, great, thanks. Those are good comments. It looks like we're running a bit short on time. I think probably time for one more question. And then I have an anecdote, personal experience with some of these issues you're talking about, but I'll share it in the round table. Presumably we'll have more time. Just something that happened with ecologic studies. So let's take one last question here, which came in, I think it was the first one. In addition to the issues related to the ecologic fallacy, I understand from epi textbooks that another issue with ecologic studies is that in the opposite direction from case control and cohort studies, non-differential misclassification will usually at least bias away from the null as opposed to the more typical towards the null that we expect often in the case control study, in cohort study. I think maybe that came, well, I first remember it from a study by Brenner and Greenland in the early 90s, I think it was, or mid 90s, somewhere in there. Can you comment on that? Do you have experience? Has that been your experience as well?
You know, that's a really interesting question. I have to admit, I'm not very familiar with that particular area of literature, so I'm going to have to take your word for it that in fact can happen. I mean, it's important to recognize, though, I would say that even for the classic results on non-differential misclassification, right, there's no guarantee that the direction of effect is going to go towards the null, right? The bias towards the null just refers to the on average, right? So you know, I think, you know, and this is not just a way of sort of waving off that question because I'm not familiar with it, but I do often caution my students in my graduate epi courses not to make too much of that non-differential misclassification result. You know, there's papers, for example, showing in simulations that, you know, in many cases, you know, you only get over slightly half the time that that in simulation studies that you actually get that the correct estimate was smaller and you know and closer to the null. You know, it's something like 51 to 60% of the time that you actually get things in that direction. So, you know, I think although it's plausible that, you know, you have some different things going on with non-differential misclassification in the ecological setting, I would just caution people not to sort of overinterpret that bias towards the null finding, because for your particular analysis that you're interested in, the effect size in any setting can be higher for non-differential misclassification. It's just slightly more likely to be lower in bias towards the null.
Okay, thanks. It looks like we're out of time. We're going to take a break. And again, thank you, Dr. Bartel, for a very stimulating you know, presentation and discussion, and we'll have time for more. There are more questions, so at the round table we should be able to address them. So we'll take a break now and come back at 12:45 for Dr. Waller's talk on incorporating spatial correlation into public health studies.